Hey guys, I'm Shalini. I'm one of the BMed Science students, and I'm going to quickly talk you through some gynae emergencies. So this is what we'll quickly go through. So I'll start with the case of PV bleeding and just a few important things to consider if it comes up in an OSCE in terms of history examination investigations. I'll then spend a bit more time for ectopic pregnancies, miscarriages, and also PID. Given fourth year presentations, if you've got an OSCE and it's abdo pain, there's also some gynae differentials to consider as well. So we'll briefly touch on that. Okay, so here's a case. You're an ED intern and your next patient is Rachel, and she's 24 years old and she's 9 weeks pregnant, and she's presented because she's had some form of spotting this morning. Does anyone want to shout out some differentials that you'd be considering? Yeah, I heard ectopic. Anything else? Miscarriage, yep. Yeah, molar pregnancy, yeah, they're quite rare, but yeah, that will be on your list. This could also just be an implantation bleed. So it'll progress into a healthy pregnancy, but they've just had a bit of bleeding. Something that I haven't listed here is also could just be from cervical origin. So they could have like an ectropion that's just started to bleed, and that's what's presented as your bleeding, or some form of trauma as well. Okay, so early pregnancy bleeding generally occurs within the first 20 weeks gestation, and it's actually quite common. So it'll happen about 1 in 5 pregnancies. Of those, just less than 2/3 will be a healthy ongoing pregnancy. So you don't really have to worry and you don't have to treat. A third would be miscarriages, and then of the remainder, in terms of that 10%, there's ectopic pregnancy, and very few cases will lead to a molar pregnancy. In terms of differentials, I've also listed something called heterotrophic pregnancies, and that's what generally occurs with the risk factor of having IVF, where you have both an intrauterine and an extrauterine pregnancy occurring simultaneously. In terms of how you'd approach this OSCE style for your history, so for the case of PV bleeding, you'd want to elicit more information about that episode. So when did it begin? What may have triggered it, if there was any trigger? Was there any trauma involved? How much blood has been lost? What's the consistency and volume? And another important question is whether they've had any clots pass. And the implication of asking about clots is to consider whether there's been any loss of products of conception. For some women who present with PV bleeding, they've also got the associated symptom of pain. So you'd also want to do your WWQQ-AA-BC for the pain. So that would be, again, whether there's been that trauma, where is your pain? Has the nature of the pain changed? The location, has it radiated? I've listed shoulder tip pain there in cases of considering if there's been a ruptured ectopic, and that's just because if you've got that free fluid in your abdomen and it irritates your diaphragm, that's where the radiation of pain will go to. And then you'd move on to a history relating to the actual pregnancy. So how far along are you? When was your last normal menstrual period? So she said that she's 9 weeks pregnant. How did she ascertain how far along she is? Was this just based on her menstrual cycle dates, or has she had any scanning ultrasounds? And also elicit any information regarding her antenatal history so far. So have you had your booking visit? Have you had your blood tests? Do you know what your blood group is? You know, are you rhesus positive and negative? And just any results. Has there been any first trimester screening? And if so, what were the results of that? And then you'd quickly go on to screen for her gynecological history. So menstrual history, periods, have they been regular, irregular? Have you had any episodes of abnormal uterine bleeding in the past? Have you had issues with fertility? Did you use fertility treatment? Was this pregnancy a spontaneous conception, or did you need to use reproductive technology to assist with that? And you'd also want to elicit if there are any risk factors that might prompt you to thinking if this could be an ectopic pregnancy or a miscarriage. So that's where you'd go in to see if there are any past histories of sexually transmitted infections or pelvic inflammatory disease, because all of that can lead to the tubal damage, which can lead to some of your differentials, and ask about cervical screening tests and if when the last test was and what their result was as well. And then you've got your obstetric history as well. So is this your first pregnancy? If not, what was the outcome of your past pregnancies? Have you had any miscarriages in the past? And I've also listed, your general surgical history, family history, social history, etc. I've listed family history there because in terms of miscarriages, a lot of miscarriages in that first trimester happen because of some chromosomal issue, most likely trisomies. So if there's something in the family that's inheritable, then that could also be leading to that presentation. In terms of the examination, so these are where most of the marks will be in terms of ensuring you do your abdo exam, you do a speculum exam to see what the state of that cervix is, and also a VE. And those will be the important findings to look for. Moving through into investigations, urine beta-HCG test would be your bedside test, but you'd also want to follow that up with a quantitative beta-HCG. Blood group and antibodies need to be taken because if there has been that sensitizing bleed, you need to check whether you need to give anti-D. FBE, and you can consider a group and hold if you think someone's hemodynamically unstable and they might need to go into theatre. In terms of your beta-HCG, there's some trends to be aware of. So beta-HCG in a live pregnancy and one that's healthy, it should double. And you should see a doubling within a 48-hour period. If it doesn't double, so if it plateaus or if it starts to decrease, that's when you think that there's been a pregnancy failure, but it doesn't help you discriminate between either a miscarriage or an ectopic pregnancy. And then if you've got an excessively high beta-HCG, that will point you towards thinking about a molar pregnancy. Progesterone is another blood test you can do to think about where the actual pregnancy has embedded. So less than 30 nanomoles, most likely to be extrauterine. Greater than 30 nanomoles would be an intrauterine pregnancy. And then you'd also want to do your transvaginal ultrasound because it helps you identify the location of the actual pregnancy. And this is just your general management, irrespective of what the actual diagnosis is. Make sure you do your doctor's ABCD and resuscitate the patient. Depending on their blood group, you will need to give anti-D. So for any bleed that happens less than 12 weeks gestation, you're going to give 250 international units. But for any pregnancy that's over 12 weeks, you need to give 625, and you've got to give this injection within 72 hours from the first episode of bleeding. Okay, so ectopic pregnancies. This is when the implantation of the pregnancy has happened outside of the uterus. It generally occurs early in pregnancy, so between 7 to 9 weeks gestation, and your most common site is the fallopian tube. So that's where 95% of pregnancies will occur. And as you can see here, the ampulla is within the fallopian tube. That's where it's most likely going to occur. It does happen, but it is quite rare for it to happen in the abdominal cavity, the cervix, or even the ovary. If someone's had a past cesarean section or some scar on their uterus itself, that's also another location where the ectopic can embed. And with ectopic pregnancies, it's never a viable pregnancy. In terms of a presentation where you've got a female of reproductive age and she's come in with PB bleeding, abdominal pain, and she's hemodynamically unstable, you need to treat it as an ectopic pregnancy until you've ruled that out. And in terms of your risk factors, you've got IVF, endometriosis and pelvic inflammatory disease are there, and sexually transmitted infections are there because that inflammation can lead to scarring and adhesions in the actual reproductive organs, and that's what predisposes to that ectopic presentation. If you've had a previous ectopic, you're more likely to have another one. IUDs can also lead to ectopic presentation. So an IUD will prevent pregnancy, but in the case that it hasn't, that's the risk that comes alongside that form of contraception. If you've had any past tubal or pelvic surgeries as well, those adhesions can lead to anomalies with your anatomy and predispose and also advanced maternal age. In terms of your presentation for ectopic, it does vary. So in some cases, it can be asymptomatic and the actual symptoms of pregnancy masks any of the symptoms that happen with the ectopic presentation. If it is symptomatic, however, you will find someone presenting with, say, unilateral abdominal pain, they may have some spotting, and that's after a period of amenorrhea associated with the pregnancy, or they might have a tender adnexal mass if you decide to do a vaginal examination. In cases of rupture, they're more likely to be associated with hypovolemic shock. So you might have symptoms of pallor, low blood pressure, they might be dizzy. Like I mentioned before, they might complain of some shoulder tip pain just because of the irritation of the diaphragm. And when you do a VE, the buzzwords in terms of signs that you look for would be that adnexal tenderness, but also if there's any cervical motion tenderness as well. And just to reiterate, investigations. So you want to do your beta HCG, quantitative, and if you've decided to do a bedside urine dipstick, that's fine too. Blood group and antibodies and baseline bloods, that's particularly important if you think that the patient's unstable and will need to go to theatre. The transvaginal ultrasound gives you that ability to identify whether the pregnancy is actually intrauterine. So features that might prompt you into thinking about an ectopic would be that the actual uterus is empty, that you can see an adnexal mass present, or that there's free fluid in the abdomen. So free fluid will be prompting you to think into thinking about a ruptured ectopic. Generally, if the beta HCG is greater than 1,500, you should be able to see something on ultrasound. In cases where someone's really unstable and they just go straight into theatre, a laparoscopy can act both as a way to diagnose but also to treat as well. So in terms of management, irrespective of what happens, check your blood group and give anti-D. If you're unstable, as I mentioned, they get referred straight into theatre. If you're stable, they'll get all of the appropriate imaging. You consider whether you want to do inpatient or outpatient management. If you're unsure, you can, and the patient's stable, you can repeat your beta HCG in 48 hours. Look for that trend and then decide what you want to do. Okay, so there's no real role for expectant management when it comes to ectopic pregnancies, just because you really do need to intervene in order to ensure it's been treated. It's very rare for an ectopic to resolve without any intervention. So medical management, the medication that's administered is methotrexate, and there's various criteria that need to be achieved before you actually decide to give this drug. So your patient needs to be stable, so it can't be a case of a ruptured ectopic. There also needs to be some knowledge that you think that she will comply to medication and to actually coming for follow-up blood tests and also appointments in the clinic, because you do need to watch them for a week. You might decide to give medical management for someone who doesn't want to do surgery, or if they have other medical comorbidities that might prevent surgery. For someone who has an ectopic in a scar or cervical or corneal location, medical management is more likely to occur because it's more effective. But generally, it's for any pregnancies that are less than 8 weeks gestation, they're stable, so it's not ruptured. Your beta HCG is less than 5,000. There's no fetal heartbeat detected. You've got minimal free fluid on ultrasound, and also that fetal pole has to be less than 5 centimeters. These are the women that you can't give medical treatment to, so you need to move and prompt them into surgical management. So as mentioned, anyone who's unstable, anyone who has signs that they've got rupture, go straight to theatre. If they have immunodeficiencies, leukopenia, thrombocytopenia, you'd be prompting them to have surgery, just because methotrexate has side effects that can lead to those blood anomalies, and that also includes your elevated liver enzymes and also the high creatinine. So those are also side effects of methotrexate, which is why if they already have these, you don't really want to give methotrexate as well. And if they're also breastfeeding at the same time, you choose to do surgical management. So in terms of counselling for methotrexate, there's some side effects that you need to discuss. So that will be mild stomatitis, gastritis, photosensitivity. They could also have diarrhea or nausea. And like I mentioned, they can have a transient elevated LFT that might come with the actual medication, but it should resolve after a couple of weeks of having the methotrexate dose. Very rare side effects would be alopecia and bone marrow suppression. When you're discussing the option to have medical management, you need to talk about the fact that there will be some blood tests that happen in the next week just to ensure that the pregnancy is treated appropriately. So they will need to be reviewed again in the clinic. There is also a risk of failing your medical management, so you then will need to move on and have surgical management as well. Given that methotrexate is teratogenic, they can't fall pregnant in the next 3 months. So generally, if they, depending on your time frames or cycles, they'd want to fall pregnant quickly, you do need to ensure they've got contraception for those 3 months, just because the effects of methotrexate can persist for that time frame. A really good resource for ectopic pregnancy management would be prompt guidelines as well, because that's where I've taken most of these notes from. So in terms of medical management, you've got options of a single dose or a multi-dose regimen. So in terms of the single dose, on day 1, the patient will come in, you'll ensure you get her baseline maternal weight and height, because that goes into the calculation of the dose. I don't think you need to know anything surrounding that formula, just know that you need the weight and the height in order to ascertain how much methotrexate you need to give, and also just baseline heart rate and blood pressure. In terms of bloods, you need to know what their baseline FB, UEC, LFTs are, and also the creatinine, just because of the side effects that can happen with the drug, and your quantitative beta-HCG, because that'll allow you to look at the trends of how the beta-HCG is changing across the next week, and then you'll calculate your dose and administer it. Again, anti-D if you think that she is rhesus negative. On day 4, you repeat your beta-HCG, and on day 7, you do all of your bloods again. So that's your FB, LFT, UECs plus the beta-HCG, and you need to review them in clinic. What you do next will depend on what the beta-HCG has done throughout that week. So in some cases, the beta-HCG, it will rise between day 1 and 4, but you don't have to be too worried about that. The main differences that you need to look at is with that change between day 1 and 7 and day 4 and 7. So essentially, you need to see a drop in that concentration of about 15% between day 4 and 7. If you don't see that, you need to think about either giving another dose of methotrexate or moving on and giving surgical management. In general, given medical management has been successful, you do need to watch your beta-HCG and make sure that falls down to non-pregnant levels, and it generally takes about 4 weeks to see that change. Given that methotrexate is a folic acid antagonist, you just recommend, as you'd recommend anyone who's trying to get pregnant, to use folic acid in their period of time when they're trying to fall pregnant again, and as I mentioned, avoid pregnancy in the next 3 months, so ensure they have appropriate contraception for that period. In terms of the multiple dose, it's very similar, however, it is a management that needs to be done in hospital. So they will be in hospital for at least 8 days. Day 1, blood tests are exactly the same. However, you do also need to make sure they've got IV access, and day 7, the blood tests are exactly the same. In terms of how the medication is given, it's just alternative methotrexate and then folinic acid, and that's just because of the folate antagonist properties of methotrexate. I think you don't really have to know the dosages or anything like that, just know that there's 2 drugs and they change in terms of how you administer them. In terms of when you choose when to stop giving this, once you've seen a decrease in their beta-HCG after they've had 4 doses, then you can stop the medication and you're pretty sure that they've been treated appropriately. Moving on to surgical management. So this is considered, to be honest, I really don't know. I generally think it's also about their symptoms, their location, and also if you think someone can stay in hospital for that period of time. So generally that 1 dose should be appropriate, but if they're not responding well, say if they're rurally and they need to come, metropolitan in order to get the management, then you might be more likely to have them present. If they've got some form of, comorbidities that make you think that, I can still give methotrexate, but they might have some side effects, so they might not respond well, then you might choose to keep them in. Okay, so for surgical management, your gold standard will be a self-injectomy. So that's removal of the fallopian tube alongside the actual ectopic pregnancy. So that's done with any woman who has another healthy fallopian tube. So she might not have endometriosis or PID. So you're pretty sure that the other fallopian tube is healthy, so that if she does want to fall pregnant in the future, you don't have any issues with fertility. However, if you, and that's just a quick diagram. So in image A, the ovary and the fallopian tube are there. Image B, it's been removed. If you want to conserve fertility, however, you can try and remove the products of conception whilst preserving the actual fallopian tube. In that case, you do need to follow up with serial beta-HCG, just because there's a risk that you actually haven't taken all of the tissue away. And so there's a risk of molar pregnancy associated. And send any tissue that you've taken in the surgery to histology. In terms of counselling, if there is a pregnancy following a ruptured ectopic, you want to do an early ultrasound just to ensure there's no complications associated with that. In terms of subsequent fertility, in most cases, there will be no ramifications. So 85% of women will continue to have no issues with their fertility. However, there will be a few women who are more likely to have a subsequent ectopic pregnancy, and there may be some who have issues with fertility as well. Okay, moving on to miscarriages. So this is when you've had a spontaneous loss of pregnancy, again, less than 20 weeks gestation. As I mentioned, they are quite common. So 1 in 5 women will experience a miscarriage. Quite a few of those will happen in that first trimester, and it's often associated with chromosomal anomalies. In some cases of miscarriage, women don't even realize that they've been pregnant, so it might just be a delayed period in terms of what they've recognized a miscarriage to have been. So symptoms can vary. You can have spotting, bleeding, abdominal pain, or they can even present unstable with that hemodynamic instability. In terms of investigations, again, beta-HCG, ultrasound, you want to do your blood group and antibodies to assess rhesus status, and also speculum. And the speculum's there to look at the status of the cervical os, if it's open and closed, or if can you see any products of conception being lost? So are they currently miscarrying? By looking at the status of the os, you will be able to identify what type of miscarriage that this is and what form of management you will need to do. So essentially, the speculum exam and your ultrasound are the 2 big ticket areas in terms of investigation to push you into what type of miscarriage this is and how you are going to manage it. So your risk factors would be both advanced maternal and paternal age, alcohol, smoking, and cocaine use. The pelvic and uterine abnormalities increase the risk of miscarriage because of just the anatomy and the likelihood of having a pregnancy embed properly in the endometrial tissue. A past history of miscarriage, once you've had 2 miscarriages, that's when your risk of having more increases, and also maternal obesity, but also comorbidities associated with the endocrine system. Okay, so these are your types of miscarriages. Essentially, you can have a miscarriage where there may have been some spotting, say in the last few days or the week. They may not have realised they've come for an ultrasound for some reason, and either the sac is small for the gestation that they should be, you can't identify a fetal heartbeat, but the cervical os is still closed. So they may have, they've missed the symptoms to suggest that they've miscarried. So you will need to treat them in either medical or surgical way in order to ensure everything's been removed from the uterine cavity. You can have a complete miscarriage in the sense that they've had some symptoms, or they currently have symptoms. Cervical os is closed. So in most cases of a complete miscarriage, they've actually miscarried the pregnancy, so you don't really have to intervene to give them anything. Incomplete miscarriage is where they're currently bleeding, so the cervical os is currently open. There generally is no heartbeat detected on ultrasound, so they will have current symptoms of pain and PV bleeding. Medical management is appropriate for an incomplete miscarriage, or you might choose to do surgical management. A threatened miscarriage is where there's an episode of bleeding, but there is a fetal heartbeat detected on ultrasound. 90% of threatened miscarriages will continue as a live pregnancy, so you really don't have to worry about management there. So you might just decide to do some serial beta HCG and just watch that trend, and if it increases, then you don't have to worry about doing anything else, and it's more likely to persist into a term pregnancy. An inevitable miscarriage is one where currently you can identify a heartbeat on ultrasound. However, there's profuse bleeding, there's some significant symptoms, and you feel as though this pregnancy is most likely going to be lost in the next few days. An aseptic miscarriage is when you've got the symptoms of miscarriage, but you've got an associated intrauterine infection, or the infection can be associated with the actual management. So they might get a fever and abnormal discharge after you've done surgical therapy. So in terms of expectant management, if you think that it's a threatened miscarriage, so as I've mentioned, it's going to be a viable pregnancy, you just have to reassure the couple. You might choose to do some serial beta HCG just to reassure. You might want to just administer some analgesia in case they've got some significant pain. For someone who has an incomplete miscarriage as well, you can consider doing expectant management. However, they may bleed for the next few, for a week or so. So you do need to counsel about that. Again, analgesia for that pain. And for anyone who is rhesus negative, just give anti-D. The risks with expectant management, however, is that your bleeding can persist. And if it persists for more than 2 weeks, you're more likely to then prompt them into medical or surgical management. There is also a risk of a pelvic infection, but the risks don't really change between expectant medical or surgical management as well. Again, about 3 weeks after, you do need to repeat a beta HCG, and that can be a urine beta HCG, and that's just to make sure that it's been appropriately managed. If it comes up as high, that's when you need to prompt into following it up with either medical or surgical management. So medical management, you choose for anyone who's stable, someone who is located close to a medical facility and has good compliance. It's better for pregnancies that are less than 9 weeks, just because the further along you are in your pregnancy, the more likelihood that medical management won't work and you might have to opt for surgical management. There's a subset of women that you can't give medical management to, and that's for anyone who has ischemic heart disease, asthma, hemorrhagic or anticoagulant use, just because the medication can propagate bleeding. So if you tend to bleed, generally you don't want to give them a drug that's going to cause them to bleed further. Any history of having an AMI, or if they've got a low hemoglobin, just again, because they might be bleeding significantly, you don't want to push them into needing a transfusion or anything like that. There's generally about an 85% success rate associated with incomplete miscarriages, particularly because medical management is most appropriate for that form of miscarriage. However, there is a risk that you will need surgical management associated with that. So with medical management, the drug that they give is misoprostol, and that is a prostaglandin analog. So essentially this drug primes the uterus to contract, and also assists with that cervical effacement in order to lose the products of conception. So it's administered either vaginally or sublingually. The first dose is 400 micrograms, and then you need to give 3 subsequent doses every 3 hours, and that can be done sublingually. So the first dose is the one where you can give the vaginal dose. The dosage may increase depending on the gestational age, or if it's a miscarriage, because you do need to make sure that cervix does open in that time frame. Given this drug facilitates contractions, there is that additional symptom of having extra severe abdominal pain. So ensure you give analgesia. And the side effects of nausea associated with the drug, make sure you give antiemetics as well. Anti-D, depending on, again, their rhesus status. And you do need to monitor beta HCG weekly until that level goes down to non-pregnant concentrations. So that's generally about 5 international units. So yeah, side effects associated with that drug would be profuse bleeding, chills, fevers, abdominal pain, and nausea and vomiting. So they're generally GI associated. In terms of your surgical management, so it's suitable for anyone who is currently hemodynamically unstable, someone who's got very severe symptoms, so they can't wait, say, for that week for the medical management to actually kick in and have effect. Anyone who has had prolonged symptoms, if they've failed either expectant or medical management, but also if someone decides they want surgical intervention because they don't want to have to deal with the bleeding for the next few weeks, it's definitely fine for them to have surgical management as well. So what you decide to do in theatre will depend on their gestational age, and 13 weeks is that time frame or that cutoff that if it's less than 13 weeks in terms of their gestational age, a suction and curettage is what's done. If it's more than 13 weeks, you need to do a dilatation and evacuation. Regardless of what surgical intervention is done, you do need to have some cervical preparation, and that's again with that misoprostol, and it's just to assist with that prepping of the cervix so it can open so that you're able to remove all of the products of conception appropriately. Again, check your rhesus status and give anti-D, and there are risks like any surgical procedure to ensure that you have counselled about those risks. Those risks include intrauterine adhesions, uterine perforations, pelvic infections. They're really rare, but just mention them. But surgical management has your best success rate, so that's about 95 to 100%. For anyone who's experienced a miscarriage, ensure that you've provided or referred to grief counselling. There are no contraindications to trying to conceive in your next cycle. However, that really just depends on their mental health status and just how the couple's going. As I mentioned, your risk of miscarriage only increases after you've had 2. So after 2 miscarriages, about 1 in 4 subsequent pregnancies will lead to a miscarriage. After 3, that risk increases to 40%. For anyone who has miscarriages in the sense of there's been 3 consecutive miscarriages, that's when you consider referring the couple on to have counselling or to have appropriate investigations, because there might be some medical comorbidities or there might be some chromosomal issues that are propagating their miscarriages. Recurrent miscarriages happen in about 1% of pregnancies. So 1% of couples will experience recurrent miscarriages. Okay, really quickly, in terms of women of reproductive age who present to ED with abdo pain, there are some gynae differences to consider. So there's ectopic and miscarriages, as we've just discussed, to consider, but there's also presentations surrounding ovarian cyst ruptures or torsion, pelvic inflammatory disease, but also your non-gynae cases of appendicitis and UTI. So if you've got a female, say she's 25 years old, she's come in with low abdominal pain, make sure you also have some gynae-associated differentials on your list. So in terms of ovarian torsion, this is where the actual ovary twists on its vascular peduncle. So on its ligaments, it twists, and it often happens because there's some anatomical anomalies. So it could be a cyst, or they might have PCOS, or there's this extra weight on the ovary that's causing it to actually turn on its axis. It can also happen in women who are having fertility treatment, because the drugs that we give make their ovaries like hyperstimulated, and that increased mass can again cause that ovary to twist. So it often presents with sudden onset, it's unilateral lower abdominal pain. There might be associated nausea and vomiting. They could also present in the form of an acute abdomen. So these women need to go to theatre immediately. You need to ensure that you do your doctor's ABCD, resuscitate the patient, ensure they're stable, and they'll go in for a laparoscopy. What they do once they're in theatre really depends on how viable the ovary is. So if you've caught it in time, then they might be able to preserve the ovary, and they might just remove the cyst that's associated with the presentation. If there's been ischemia and if there's necrotic tissue, then the ovary and the fallopian tube often will be removed. In terms of a ruptured ovarian cyst, so cysts on ovaries, they're quite common, particularly for women of reproductive age. So often women who present with a cyst rupture, they have a history of documented cyst on an ultrasound that they've had in the past. They can also present with an acute abdomen, just because dermoid cysts, just because of the irritation of blood or teeth or hair, or all of those different tissue types that are present with a dermoid cyst are quite irritative. So when that reacts with the actual peritoneal layer, they can cause some really significant pain and peritonism. And this generally presents as unilateral sharp focal pain. If they're stable, you might not have to do anything, so you might just monitor them and give them some analgesia. But if they are unstable, they've got hypovolemic shock, they've got peritonism, that's when you need to send them into theatre. They'll have a laparoscopy, and again, they might just have some irrigation, suction, just cleaning away of any of the tissue that's actually ruptured into the abdominal cavity. They might have removal of a cyst that's still present, or in some cases, they might have to take the ovary if there's been a lot of hemorrhage associated. Okay, pelvic inflammatory disease. So pelvic inflammatory disease, it's an acute ascending inflammation and infection of your upper female reproductive tract. So it can involve any of the organs. That could be your uterus, your fallopian tubes, the ovaries. In some cases, the mucopurulent discharge can actually move out of the fallopian tube into the actual abdominal cavity. So that can lead to actual pelvic peritonitis. You can also then have abscesses forming, so either on the fallopian tubes, the ovaries, or even on the pelvis itself. PID is polymicrobial, so there are many organisms associated with this presentation. Most cases, it's associated with sexually transmitted infections, and chlamydia and gonorrhea are the two primary organisms implicated. However, in a subset of the population, it can be associated with just the lower genital tract bacteria. So that will happen in women who've had some form of cervical instrumentation. So they may have had an IUD inserted, or they've had a hysteroscopy, and just the association of having that instrumentation has led to some infection. So that will just be any other bacteria present on the lower genital tract. Your risk factors would be being sexually active, having multiple sexual partners, and a history of unprotected sex, past history of STIs, if there are partners who've had STIs, and if you've had like an IUD inserted or like instrumental management. Symptoms can vary, but generally it's bilateral lower abdominal pain. There's fever, nausea, vomiting. There might be a history of having some abnormal vaginal discharge and PV bleeding. They might also complain of pain on sexual intercourse or deep vaginal pain. I've also listed perihepatitis here, so it's one of your buzzwords. So someone's come in with, symptoms that point you towards thinking about an STI, but they also have this right upper quadrant pain. Perihepatitis is associated with PID with chlamydia and gonorrhea. So the infection spread through the fallopian tube into the pelvic, the actual abdominal cavity, and there's been adhesions formed between the actual capsule of the liver and the peritoneal layer. So your buzzwords are like those violin string adhesions that they see on laparoscopy between the liver and the peritoneal layer. On examination, vital signs might prompt you towards thinking about an infection. There might be that low abdominal tenderness, guarding, potentially. On VE, there'll be cervical motion, excitement, and also adnexal tenderness. Investigation. So given that they are infectious, you'd consider doing FBE, looking for your white cells, CRP and ESR, a pregnancy test because you want to rule out an ectopic pregnancy, and then you'd need to do relevant testing for the STI or for the infection. So endocervical swabs, send it for PCR for gonorrhea, chlamydia, given those are your two most common organisms. You might decide to also do urine MCS. Depending on the risks, the risk factors, you might also want to do hepatitis, HIV, and syphilis serology, just with the associated infections. You may also want to do an ultrasound or a laparoscopy, just depending on how they're presenting. If you think that there's an abscess, that's when you'd be more likely to go towards doing a laparoscopy. So in terms of the general management, if they've got an IUD in situ, you do need to take that out and then discuss contraception since you've taken away their IUD. Depending on how severe their symptoms are, you can either manage in the community or in hospital. So you do this through antibiotics. So for anyone who is mild or moderate, they can be an outpatient, so in the community. So you will give them 3 drugs. So ceftriaxone and azithromycin are your just 1 dose, and that's enough. And then you Continue with 2 weeks of metronidazole. So essentially, azithro targets chlamydia, Kef targets gonorrhea, and your metro targets your anaerobes. For anyone who is severe, they need to be in hospital because you need to give some drugs IV. So it's Kef, metro, and azithro, but Kef and azithro are IV. Once you see change in their symptoms, so as soon as they start to get better, you don't need to give them IV meds anymore, but you substitute and you give them doxy instead, and it can be done orally, so they can then be discharged. But you do need to see that clinical improvement before you move to oral medications. For anyone who has an ultrasound and you've found an abscess, that's when they need the laparoscopy, or if they've been unresponsive to your antibiotic treatment. So that'll allow you to actually drain the abscess. If you're also not sure if it's PID, it'll allow you to look for any other diagnoses like endo or an ectopic pregnancy or ovarian pathology as well. Given this is often associated with STIs or unprotected sexual intercourse, you also need to ensure you've got appropriate counselling. So that would be screen any partners and treat them, because you will then remove that reinfection risk. If they're on, say, the COCP or an IUD, also ensure that they've got barrier protection. Talk about fertility, especially if they've got a history of past STIs, because all of that inflammation can lead to adhesions in the actual fallopian tubes, and it can affect their future fertility risk. And that leads to your further complications of having an ectopic in the future, subfertility, or even chronic pelvic pain syndromes. Okay, the last thing that I'm going to briefly talk about, which will be like 5 minutes, is termination. So essentially, termination, it will change depending on the state that you're in. In Victoria, it's legal, but for any pregnancy that's after 24 weeks pregnant, that's when it needs to go to a tribunal. So there'll be a committee that actually decides whether it is appropriate to have a termination of pregnancy. Women will request a termination for a vast, there'll be many reasons. That can include having medical comorbidities that make it unsuitable for them to be pregnant at that time, or it might be for other reasons happening with their social circumstances. There is medical or surgical management. In addition to thinking about how the medical or surgical method for termination, you also need to counsel regarding unprotected sex. So depending on what's happened that's led them to having a termination, you need to assess whether they're at risk of STIs. Do you need to do swabs, urine tests? Do you need to do serology for HIV, hepatitis? Are they at risk of those presentations as well? And also discuss future contraception. So you want to reduce the risk of them coming for a subsequent termination. So have they used termination and has that failed? Are they not compliant with their oral contraceptives? So you need to think about an IUD. Are they also using condoms? So you need to also discuss contraception. So in terms of medical management, you've got 2 drugs that are given. So mifepristone, it's also known as RU486. This is the progesterone antagonist. So essentially, progesterone, it's your pregnancy maintaining hormone. So you give this drug so that progesterone doesn't have its effect. So, and then 36 to 48 hours later, you give misoprostol, and that can be done either vaginally or sublingually. This is the prostaglandin analog, so it facilitates contractions and those cervical changes so that you're able to then lose the products of conception. You have increased success rates if you give both drugs together. However, 5% of women will need surgical management. These are the women who you cannot give this to, and you will then move to surgical management. These are precautions and side effects. I've just taken this out of prompt. So prompt is another good place to look at notes for termination. Essentially, depending on your gestation, the dosage of misoprostol will change. So you've got 800 micrograms for anyone who's about 12 weeks or less, but if they are 12 weeks to 24 weeks, that drug dose, you might have to give increased doses, but it's there on prompt if you want to look at that. And then this is your surgical management. It really depends on the gestation. If it's less than 12 weeks, you do suction and curettage. If it's more than 12 weeks, that's when you do dilatation and evacuation. And you will also give them antibiotics to prevent any infection. So they just get doxy prophylactically. Those are your complications and some side effects associated with it. Complications are really rare, but ensure that if it does come as an OSCE, that you just talk about them. And again, discuss contraception and STI use. Yeah, I think that's it. I'm really sorry for rushing through it, but I hope you've got enough information there. We didn't get PV bleeding for our OSCEs last year, so you might get it this year. So yeah, just look at in terms of what you want to do for management and just think about it in terms of an OSCE, because that might be the easiest way to study for miscarriage and ectopic. Cool. Thank you.